Hello, everyone. My name is Sarah Zutrauen. I am an epidemiologist with the Centre for Surveillance and Applied Research at the Public Health Agency of Canada. And today I will be presenting on behalf of Stephen McFaull, Wendy Thompson, and our injury surveillance team on sports and recreation concussion surveillance. We'll begin the presentation by reviewing some of the data sources we use in injury surveillance. In particular, for concussion surveillance, emergency department visits. We'll also discuss an upcoming concussion survey and then discuss some of the challenges involved in concussion surveillance. Before focusing on sports-related concussions specifically, we'll focus on an overview of all head injuries to put concussions in perspective. The next few slides will highlight sports and recreation concussion surveillance from the National Ambulatory Care Reporting System, known as NACRS, and the Canadian Hospitals Injury Reporting and Prevention Program, known as CHIRP, and finally some concluding thoughts. The injury pyramid is a common concept used in injury prevention. It can be used for injuries overall or for a specific mechanism or diagnosis. The outcome or treatment is shown with increasing frequency as we move down the pyramid. The data sources associated with each segment of the pyramid are shown to the right. For fatalities, we use Statistics Canada Vital Statistics Death Database and the Coroners and Medical Examiners Database. For hospitalizations, we use the Hospital Morbidity Database for older data and the Discharge Abstract Database, known as DAD. Emergency department visits are captured in NACRS and CHIRP, which we'll talk about more in the next few slides. Treatment in primary care is captured by some surveys and physician billing databases, but is less used. The base of the pyramid represents the unknown frequency, and note that some surveys can span multiple segments of the pyramid. And for concussion surveillance, we do rely heavily on ED visits and recently surveys. The two main sources of ED visits we use are NACRS and CHIRP. NACRS is managed by the Canadian Institute for Health Information. It contains all hospital and community-based ambulatory care, including emergency departments. While other provinces do submit to NACRS, only Ontario, Alberta, and Yukon Territory have complete coverage and allow the calculation of population-based rates. And NACRS uses ICD coding. CHIRP is a sentinel system operating in 19 emergency departments across Canada. It's not population-based, but it provides more detailed information through a narrative description, which we'll show some examples later in the presentation. CHIRP has an expanded code set for sports and recreation, which allows identification of any sport or activity, whereas the ICD codes in NACRS are limited and some sports cannot be identified. We recently did some collaborative work with Statistics Canada aiming at better understanding the incidence of concussions among the Canadian population aged 12 years and older. This was done by supplementing the 2020 Canadian Community Health Survey with a rapid response module. In addition to getting a national estimate of concussions, we also examined information on the circumstances surrounding respondents' concussions, such as the locations in which the concussions occurred and whether they were due to sports, falls, MVCs, and so forth. The findings are scheduled to be published in health reports in July of 2023. With regards to concussion surveillance limitations, gaps, and challenges, in Canada, deaths due to concussion are very rare, and individuals are not often hospitalized for a concussion. Therefore, emergency department surveillance using NACRS and CHIRP remains the most important data source for concussion surveillance at the moment. There is recent evidence that individuals are seeking or obtaining treatment at other points of care. Surveys are also another source, but to date, that data has not been routinely collected. Another challenge is that administrative data is not complete or timely, and not all sports or recreational activities are identifiable in NACRS or DAD. The next two slides puts concussions in context relative to other head injuries. TBI includes concussions, and all head injuries includes TBI. We can see that very few concussions are hospitalized. The ones that are hospitalized likely include other injuries as well. This slide shows the rates of hospitalization and emergency department visits for males. We can see very similar results for females, where higher rates of concussions are seen in emergency department visits. This slide shows the 12-year trend in concussion rates for emergency department visits for both males and females. There was an increase from 2010 to 2015, after which the rates leveled off. The pandemic has caused a temporary distortion in the trend. Continued surveillance in the coming years will be crucial to reveal the new ED visit rate levels. Some of the early increase was likely due to increased reporting due to the awareness resulting from high-profile events such as Sidney Crosby's missed games and the death of 17-year-old rowing stringer in Ottawa due to multiple concussions. There are some Ontario studies showing an increase in physician office visits for concussion during this approximate time frame as well. The next two slides show the breakdown of ICD grouped sports and recreational activities for females and males aged 5 to 29 years for a single year just before the pandemic. For females aged 5 to 9 years, playground equipment has the highest rate, while for 10 to 19-year-old females, ice hockey, football, rugby, and other ball sports have the highest rates. These groupings show some of the limitations of ICD sports and recreation coding. For males, we can see here that ice hockey predominates. Moving on to the CHIRP system, these next two slides are taken from a 2020 Injury and Review report. We ranked sports and recreational activities by the proportion of all injuries that were traumatic brain injuries by sex and age. This slide shows the results for 15 to 19-year-old females. You can see that 44% of all ringette injuries are traumatic brain injuries, mostly concussions. For 15 to 19-year-old males, rugby is the most frequent, with 27% of all rugby injuries being traumatic brain injury. As indicated previously, the CHIRP contains a narrative describing the injury event. This slide shows example narratives for martial arts and ice hockey. For example, for martial arts, participating in a karate competition kicked in the head. And for ice hockey, playing hockey, went to get the puck behind the net and was cross-checked in the head. This slide shows sample narratives for rugby and soccer. For example, playing rugby was tackled head-to-head collision. For soccer, struck to the left side of the face by a kicked soccer ball. In conclusion, concussions associated with sports and recreation are common among those aged 5 to 29 years. Emergency department surveillance using knackers allows the assessment of the burden of concussions, whereas emergency department sentinel surveillance using CHIRP allows more specificity and the identification of circumstances which can inform injury prevention initiatives. Thank you so much, and you can contact any of us for further details.
Excellent. Thank you so much, Sarah. And I look forward to seeing Stephen on the screen here as well for the live Q&A. Hi, Stephen. Nice to see you.
Hello.
Excellent. I have a few questions for you this afternoon. First off, I know in your presentation you explained why going to the emergency department is a great source of credible data for your research. However, with hospitals experiencing high patient volumes and long ER wait times, going to the ER may not be the best place right now for people who suspect a concussion to go visit. So where else might they go for treatment when a concussion is suspected?
Well, what we do is the surveillance. I don't know that I would answer that in terms of not having a clinical background. We would always urge people to go to the to get help if there's a suspected concussion. I know lately there's been a little bit of a problem with wait times, etc. But what we're doing is looking at where people go when they do get a concussion, looking at the trends there. But I don't think our group is necessarily positioned best to answer that. It'd be more on the side of potentially Dr. Zemek or Dr. Tatter, I think.
Okay, that sounds good. Thank you for that. How could sport organizations support or be involved in better concussion surveillance? And I'll leave that for you, Sarah, maybe this time.
That is a very good question. And thank you again for having us. We're very excited to be here. So as Steve kind of mentioned, I guess our role is really on the injury surveillance side. So currently, as we kind of alluded to in our presentation, emergency department data is one of the most important data sources that we use. Not to say that other points of care, individuals should still continue to present to other points of care as needed. From our standpoint, really, the National Ambulatory Care Reporting System is very useful to us because it's such a large administrative database that we have access to for surveillance, and it allows the assessment of the burden of concussions, whereas CHIRP, though not national, it contains detailed information that allows us to kind of get into the contextual details of what happened during the injuries. So those are the main two data sources that we kind of have access to at the moment and rely on. Not to say that we wouldn't be interested maybe in looking at other data sources. That's always definitely on our minds of how we can kind of, use other data sources to provide a more complete picture. But definitely in our minds and open to, figuring out other data sources that might be available. Steve, do you have any thoughts on that?
I can add just a little bit. Yeah, one of the things we're always looking for is we have the numerator data, of course, but we're always looking for denominator data. So for the knackers and the DAB, we use just the population numbers there. Of course, not all those people are exposed to this particular sport in question. So better denominators, if we could have registration data, numbers by age and year, that would enable us to generate better denominators and potentially more meaningful rates.
No, that sounds good. And I know these are not easy questions, so thank you so much for providing those answers. We have a question from the Q&A box that's actually really interesting, and hopefully you have some information. A similar study of ER visits for adults with concussion found that equestrian had the highest rate of concussion per hour of activity. Was a per hour of activity data possible to factor in?
No, that's kind of one of the things we're asking for too, because that's the best type of denominator is where we know the actual number of player hours or number of player games. So in that case, we don't have that information. We get the sports that are coming into the ED visits and the types of injuries and demographics, et cetera, where it happened. But definitely that kind of information would be very useful.
Sounds good. And I'm just going to piggyback on Amanda's presentation earlier. I'm just curious, really, have you also looked at the breakdown of concussion by other demographic factors, such as race? Was that data available to you?
No, in the database that we have, we don't have that information. In the CHIRP database, we used to have, I guess it was a proxy for ethnicity, which was language most spoken at home, but some privacy issues and some data quality issues required that we remove that variable, but not to say that we couldn't re-implement that at some point. But currently we don't have that information. Again, it would be something very interesting to have.
Sounds good. I know, following up to Amanda's presentation, the Drive and Change Spotlight, identifying some gaps, I think we found some opportunities to get more information and to ask different type of questions as you continue with your research, which is, it's always good to know what we need to know, right? So again, I would like to thank both of you for joining us today and being part of our symposium. And I wish you a great rest of an afternoon.